Hi, everybody. Thank you for joining us today. We're really glad to be with you today. I'm with the Emerson Collective. Kiah is from SIRUM. And we're really excited to talk to you today about the relationship between people who are able to bring resources to work and then the excellent work that people do when resources in all different flavors and varieties come to them. I'll tell you a tiny bit about the Emerson Collective, which is where I do my work, and then I'm going to turn it over to Kiah. I know both of us underscore that we hope you're in places where you feel healthy and safe, and that we're very, very honored that you are taking time to spend time here and to learn about ways that both tech and kind philanthropy and giving can make a difference in the world. I'm with the Emerson Collective. We do our work in a very broad way, a number of social justice issues we take on, including education, immigration, the environment, and health. I lead our philanthropy team there, but Emerson also has investing teams, communication, convening, advocacy. We believe using many tools can lead to great social change. And I'll also acknowledge that we have a fairly large capacity building program we run because we think so much of good work is about helping teams and individuals to feel supported in their work. We may talk about that more later, but for now I want to be able to share or let Kiah share all the work that SIRUM does and how much that's been growing and changing access to healthcare for people in America.
Hi, everyone. My name is Kiah Williams. I'm of SIRUM, and we connect surplus unused medicine to people who need it most in the United States. This is all leveraged through a technology platform that allows organizations that have surplus, like nursing homes, pharmacies, hospitals, to donate their unused medications. So really simple to like a recycling program, except for it's for medications that would have otherwise gone to waste. And so we use this technology platform to connect hundreds of facilities that have surplus. And our goal is to get to the about 10 million low-income adults in this country who have a chronic disease and are having ongoing issues affording their prescription medications. What else? So we are a ever-evolving organization, and happy to chat a little bit more about how we went really from a B2B, tech-only platform to evolving our model to include policy and include kind of some direct-to-consumer elements.
Hey, Kiah, can I ask you to do that? And one of the lenses I really appreciate about your work is how you think about the individuals you serve, the communities they live in. Your work has a really interesting and important state-based component. And then honestly, you're thinking about how to help people to understand equitable access to healthcare across the US. So can you unpack your model through that lens? Because I think that would help people to both understand it operationally and understand it spiritually too.
So, I think taking a big step back and kind of the system of healthcare in America, which I think we all know, is a system right now that really has a lot of folks there's a haves and have-nots. To some extent, we have in the United States some of the best world-class healthcare, just groundbreaking. But at the same time, like the base level of care we're providing folks is just honestly does not do justice to like what I think we as a society, as a nation believe in. And so teasing part of that apart is, so a lot of folks think about kind of just insurance as like an end all be all in healthcare. I think what's really important though is increasingly you're just seeing folks who have high costs of healthcare, whether it be from a doctor's office visit, a monthly premium, or prescription drug. So what's really important to know, so in the United States right now, the average family spends about $3,000 a year on their prescription drug costs. To kind of frame that for folks, for a low-income family in this country, that ends up being around 10% or more of their income. And so to frame that additionally, what that ends up being is about the same amount people spend on groceries. That is what they're spending on prescription drugs. And so what we have basically seen is this very crucial linchpin where affording medications is kind of the difference between someone falling into poverty or falling deeper into poverty. And the reason is because, you know, folks, especially if you have diabetes, heart disease, et cetera, like if you have a chronic condition, if you're not getting that base level of medications that you need, what is likely to most likely happen is you're ending up in the emergency room, you're ending up hospitalized, you're ending up with a lot of medical debt. And so the number one reason folks declare bankruptcy, you know, in the United States right now is because of medical costs. So what we've really seen is that just this one issue of if someone going to get their medications this month has this kind of huge ripple effect on their life economically, and then also also in terms of their health. And so what we kind of identified was this one piece that no one else is really working on. You know, like folks are working at a very large level around kind of healthcare reform, et cetera, but there's this one piece that was really missing. And at the same time, what really spoke to us as like this incredible injustice was at the same time as these millions of folks are not getting the medicine they need, there's about $10 billion of unused medicine, that exact same types of medications that are going to waste. And so the way our model really started is first just thinking of ourselves as this kind of peer-to-peer networking platform that connected organizations who had surplus with organizations, safety net clinics, that were seeing low-income patients. As we've grown in scale, and that model has worked beautifully in some instances, especially in instances like the Bay Area where there may be large healthcare systems, where we have seen that that did not work quite as well and just wasn't doing the best that we could do for patients, is actually in just areas that had more disparate healthcare systems and health and safety net. And we've actually seen this kind of, we took the model in the Bay Area, we started replicating it across other states, and really found that the safety net is really fragmented in other areas. And so when safety net, I mean, you know, where are people going to see a doctor? How are people getting access to medications or tests that they need, et cetera? So I think as we kind of continue to evolve and start thinking about our mission, not just as this connector, but, you know, of the organizations with surplus and the organization with need, we started actually thinking more about the vertical integration that we could have. Basically, how could we actually see this process the entire way through, from the organization donating all the way down to the patient? And how could we make sure that that experience was one that was like, honestly, like what people deserve. And I think for us, what it really came down to is we started, you know, adding more services until what we realized what we were doing is basically creating a wholesale pharmacy access service for low-income patients from kind of soup to nuts, because what we realized is that there was nothing like that existed. And what was happening is we were expecting people who are poor to spend so much more of their time and resources trying to access very basic needs. And so what we decided to do was launch the platform, and still using technology in so many ways, but launch a platform wherein, folks could get medicine as easy as you or I get, a 2-hour Amazon Prime Now delivery or a DoorDash order. Like, why we should have those same levels of service options. People should be able to get medications delivered to them that they need to survive pretty easily. And so that's what we're building out for low-income people.
So, I mean, one of the things I've appreciated about SIRUM's work, and I've gotten to know their team over a number of years, is it was always built off this really strong belief in the power of listening and being proximate. I mean, I think the amount of time that this team has spent talking to people across the value chain, the people who are receiving the medicines, the people who are donating the medicines, I think has really changed. And your willingness to iterate and question and be curious has made such a big difference. One of the other things I've always also admired is that you are willing to do sort of unforgiving iteration, that you've tried all different things to see how they work. And I'm also thinking, if you're sitting out there and you're an entrepreneur and you're hammering away at something, two of the other things I'd highlight about your team, one is that you've always been incredibly hierarchically flat. You really allow each person to lead. And it isn't as though you don't have ways you make decisions, and it isn't as though people don't take responsibility. You have enormously challenging goals, but that hasn't made it harder. It's actually made it easier because of the way you've shared responsibility. One of the things as I think about the story you told, though, that I wanted to ask you to share more about is more explicitly how you've thought about policy and advocacy, because I think that has been such an important component of your work. In some ways, you're like in a car and the car gets to a wall and then someone has to open the door for the car to go through the wall. And it's like what you do while you're driving the car. So when you get there, the person knows you need the door open. But I think some people don't know where that line of where policy and advocacy should begin. How much credibility do you need to have? Who can do that? I wondered if you could unpack that for people, because I think your team has been so smart at figuring out locally on a state level beyond that, where to start and push on those conversations.
Good question. So just to kind of level set for folks listening, the reason our work is able to happen now, it would not have been possible 10 years ago, 15 years ago in the way that it is now. It's because at a state level, states have passed Good Samaritan drug donation laws. And so those are really similar to the laws that allow, a restaurant to donate unused food at the end of the night. These are laws that are pretty common sense, to be honest, that allow institutions that have unused, unopened, unexpired medications. And these are also not controlled substances, so it's not opioids. So basically, before these states had these laws, these medications had to be discarded. They had to be sent to a medical waste incinerator. In some states, they're actually, still today, the alternative is actually to flush them down a toilet. And we've actually seen policies that show 2 nurses go to a toilet, one pours, one flushes, and that's how you get rid of medications. So first thing to kind of note is I don't think we ever sought to go into policy, if that makes sense. That was not one of our stated goals. But what we quickly learned is, especially in healthcare, anything that is very regulated, policy is going to rule the day on what you can and cannot do. So I like to talk a lot about what we do as little p policy, not big P policy. And the reason for that, and I think a lot of folks are unaware, is a 501c3 organization, you can still do some policy work, and I think a lot of organizations are like, well, what does that mean? Does that mean supporting candidates? Does that mean, giving money to campaigns? Does that mean canvassing? What it generally means for a lot of nonprofits, and where we've really found a sweet spot, is how does your work impact the communities you're serving? And how do you bring that work to decision makers, to policy makers, and let them see the impact that, policy can have? So for us, that meant very, very early on, because we could only work in, within the boundaries of what this policy is, it meant going to some of the state legislators, state senators, state assembly members, and saying hey, we wanted to let you know our work exists. It exists because these laws that you all passed, and we want to share what the impact has been. I will say that a lot of nonprofits probably don't think you could just literally pick up a legislator's, you pick up a phone, you call their office, you can get an appointment with either the legislator, their legislative director, et cetera, just to share your work. And one of the things I would say, especially for starting up entrepreneurs, et cetera, is they are incredible networkers. They're incredible connectors. So much of the work that they do is weaving together policy with the social sector and with the business sector. So we just got incredible connections just from saying hey, we're here and we're leveraging this work. The other thing I will say is a lot of nonprofits, I think, are not as aware that policymakers, they want to show that the work that they've done, that the laws that they've passed are helping actual people. So much of the time they're seen as oh yeah, you're in Sacramento, or oh yeah, you're in DC, or whatever your state capital is. How does that work actually drive impact on the ground? So they love to highlight the work, especially that the social sector does, because we are seen as very nonpartisan, because we are organizations who are doing this work. So I think for us, it started out as just saying hey, we wouldn't exist without, these policy measures. We just want to share more about how these laws are impacting the lives of people in your district. From there, as we continued, so we had really no asks. We really just wanted to share what was going on. From there, what we started to realize is that policymakers were really hungry for policy that could impact change on the ground like we were having, especially ones that could be quantified. Like the fact that we could say we have this many millions of medications going into your district, or this many prescriptions helping this many people, that is like catnip, I think, for legislators and for policymakers. And so what we started to realize also is we could start, when we started getting bigger, when we started showing like, hey, this is really being successful, we could also say, like, they started coming to us and saying, well, what do you need to make this bigger? What do you need to make this better? And I think that's where you create this incredible, real partnership where they want to see change happen in the communities that they care about. And you're the ones who's impacting change. And from there, Anne-Marie, and I think we've shared a lot of this, we started being able to say, well, what are the changes in policies? What are the areas that we can actually make some of this policy better to make it more impactful? So I'll give a for example here. In the state of California, we helped with some legislation because there were only a certain subtypes of healthcare facilities that could originally donate their unused medicine. As we started going out into the field, we started realizing, hey, there are these other organizations, there's mental health facilities that couldn't donate, there's assisted living facilities that couldn't donate. As we started going out into the field, we started realizing that there were whole types of organizations, thousands of institutions that were not originally contemplated in California's Good Samaritan legislation. And so we went and we shared that with the legislators and said, hey, there's like a few thousand other organizations who could be eligible to donate, but right now the law says that they can't. And that was like a legislative fix that they were happy to kind of just carry as a bill and move forward and get done. And so I think what we started to realize is we can create this really virtuous cycle with policy where they are providing the scaffold that you can operate within, and then you are doing the work and proving that it can be successful for communities they care about.
It's so interesting because actually in the same way you've done execution on your work, being curious, listening intently, iterating, kind of letting the future and the past come together, that's a little how you've done your policy work too, that same kind of process. I have one other question for you, which is about storytelling. And part of me suspects that because you have a focus on people who are the most vulnerable, because you have a focus on healthcare, because there's also a really interesting environmental access that you could talk about. I'm curious how you think about storytelling in kind of a mass way, and then with different audiences, how you might think about storytelling slightly differently, because you have such a rich diversity of ways to tell stories, and then you have so many people each day whose lives you fundamentally change.
Is actually one of our weakest points as an organization. Like we are, myself and my co-founder team, like we are very, very data driven. And one of the reasons we're able to stay very flat, one of the reasons that everyone and anyone should be making decisions that move the needle is because we always come back to like, what does the data say? What is it telling us? And does it change the answer? Right? Like, I think that's just, we literally have a internal thing where someone will yell squirrel when we're like, we're not on focus around making the right decision based on what the data says and like what people in the field are telling us, what our users are telling us. So we are very user focused, whether that's a nurse who is packing the box to send for a donation, whether that's the clinician who's writing a prescription, whether that's a clinic pharmacy technician who opens the box and receives it. Like we are very focused on the user experience that we create for people, and a little bit less on our own, hunches. I would say the reason that we're less good at storytelling is because to us, I think in a lot of ways, the data is what tells the story. And I think that what we have learned, though, as an organization is like that really works for certain audiences, certain funders. Like we can just geek out over large, sets of models, but it doesn't really provide kind of a real human face to the work that we're doing. And so I think that it's actually one thing that I would say we've most struggled with and especially because it's healthcare, especially because there's HIPAA, so there's privacy concerns, especially because I think, beyond just like, oh, there's this, policy concerns around, whether what you're sharing about people's health statuses, I think we're also like just very keenly aware of potential like discrimination and and wanting to also share stories in a way that truly honors and empowers the folks that we are serving and of service to, rather than being kind of like a poverty tourism, kind of vibe. I think that being said, the stories that we try to tell and the way that we try to collect them now we try to do it in a way that is not just us constantly asking for people for stories. It's basically as a way for feedback. I think that that's like the strongest thing that we've pushed towards, is like, we shouldn't just say, I want your stories, I want your stories. We should also figure out how can we collect stories as a way of collecting feedback on how we can actually also improve. So the way we think about storytelling is a little bit complicated because we have all these different user groups. We want to be respectful and make sure we're telling folks stories in an appropriate way. But I think the other thing that we've come to realize is that people sharing their stories with us is also an incredible way to gain feedback.
That's so interesting. So I recognize we have a handful of minutes left. And so I'll share something at the end just as a frame out for us. One of the things the AGG team had asked if I could share was how spiritually the Emerson Collective thinks about our philanthropy. And what I would observe is we come from a place of building relationships, of listening and learning, of meeting people where they are. All of our grants are general operating. All of our grants are unrestricted. And I'll finish by saying there are hundreds and hundreds, not that she is not fabulous. There are hundreds and hundreds of Kiahs out in the world doing work, and they're figuring it out as they go along. They set audacious goals. Sometimes they hit them. Sometimes they fall a little backwards, and then they claw forward in a way that takes your breath away. And so the reason we've come to do the work we do and the way we do it is because we seek out leaders, we seek out models, we look for people who are listening, we look for people who are looking both at the people they serve and care for every day and the bigger systems in which they sit. And that's then where we put dollars into that kind of problem solving. And so I wanted to highlight for folks out there who are in a position to bring resources to work, that finding that flexibility and that joy in the way you bring resources and the way you see what assets you have and you provide them to work is very powerful, and then allows folks like Kiah to simply go out and do the work they do best each day. And then Kiah, I wanted to thank you for hanging out with me.
Anytime.
Be well.
Thanks, everyone.